Good afternoon, everybody. Thank you very much for come join us with the Tea Time Seminar 1. In this seminar, we will share the result of a very important recent prospective registry of newly diagnosed of atrial fibrillation. Our registry is namely GARFIELD-AF. So the principal investigator is Professor A.J. Keika at the University College of London. He said he cannot come because he has to, give an appointment for the Supreme Court of UK because he's one of the member of Lord. But I'm very pleased to chair this session with Professor John Kam. He kindly came from long way from the UK to here. So now we will start with this Tea Time seminar with the presentation by Professor Toon Wei Lim from Singapore. He will talk about atrial fibrillation treatment strategy in Asian country. Professor Lim, please.
Okay, thank you. So I'll move on with the first part of our presentation this afternoon, which is a global overview of the GARFIELD-AF study. Many of you are probably familiar with this study already. It is one of the largest ongoing global disease registries in atrial fibrillation. And the unique thing about this is that it targets patients with newly diagnosed non-valvular AF, which is defined as being present for less than or equal to 6 weeks with at least one investigator-determined risk factor for stroke. And the purpose of this presentation is to describe the baseline characteristics and antithrombotic treatment patterns in patients with newly diagnosed AF from the countries from Asia, namely China, India, Japan, Singapore, South Korea, Thailand, and compare them with non-Asia countries. As mentioned before, this is the largest AF and is a prospective non-interventional disease registry with newly diagnosed patients from 35 countries across the globe. There are over 1,000 sites from representative AF care settings as determined by the national coordinating investigators. And also quite an important feature of this is that 20% of all case report forms are monitored against source documentation at sites to ensure the data integrity. The patients in this AF registry were recruited over 5 consecutive cohorts, each cohort running for about a year. Initially, the plan was to follow up all patients for at least 2 years, but since then it's been extended for the earlier cohorts for an up to extra 5 years follow-up. And so the last cohort, which has closed, will also be followed up for 2 years. At present, there are 57,150 patients enrolled, and we have up to 1 year, minimum 1 year of outcome data as of now. And this map just shows you the global reach of this AF registry with countries recruiting patients in blue, and they basically span all the continents of the globe. The countries of interest are on the left-hand side of your panel. The largest of the Asia-Pacific groups is Japan with over 5,000 patients, followed by China, India, I think that's Thailand, and somehow Singapore is missing from that. We are the minnow in the group, and we are in 305. Maybe the font's too small to see. In terms of the proportion of the patients, Asian patients, which are in the maroon color, are up 26.6%, just over a quarter of the entire cohort, so a very significant part of this study. Here again is the breakdown of the 13,835 patients from Asia, broken down into the individual countries. As you can see, Japan forms just over 1/3 of the cohort, but there are also important groups from all the other countries. And although Singapore is quite a small proportion of the cohort, we are actually quite a small country to start with. Here are some baseline characteristics of the patients. As you will notice, while the non-Asian cohort has an average age of 72, which is matched by what is found in Japan, most of the Asian cohort is relatively younger, and overall about 4 years younger than the non-Asian cohort, with a bigger proportion as well of patients in the younger age groups. In terms of the type of AF, it mostly is similar to the non-Asian countries, except there is some discrepancies in this because of the way that patients are classified in each of the countries. For example, in Singapore, there's a large proportion of patients who are at study entry classified as new because the investigators considered that it was not possible at that point in time to determine what type of AF they have. But on the other hand, in Japan, the larger proportion were classified as paroxysmal. In terms of the care settings, again, you will see that in Asia, the largest proportions are going to be in cardiology, but there's still also differences in between the various countries. There is a significant proportion, as I mentioned, between 81% to 91% of patients cared for under cardiologists, but this is significantly lower in the Thailand group with 55% only. And in Thailand, there is a significant proportion in primary care, which also is similar to the non-Asian cohort. And of course, there's the other groups in internal medicine, geriatrics, and neurology as well. This is a graphic of the use of antithrombotic therapy. I will not go into too much detail because there are far more detailed discussions later on about this. They follow the same pattern where the light blue down the bottom are patients on vitamin K antagonist. The red are patients on so vitamin K antagonist plus minus antiplatelet therapy. The red represents the direct oral anticoagulant and plus minus antiplatelet. Green represents patients on antiplatelets, and the top bar and purple is patients on no treatment at all. And you will see that the clear pattern is that there's an increasing proportion of patients on anticoagulation, and in particular in the novel anticoagulants. This is an overview of the patterns of use of these antithrombotic therapies across all the countries in the global cohort. And you will see that there is marked variation between all these. Again, I won't go into detail because there will be more detailed descriptions about that. I would like next to hand over to Dr. Pantip Angchai-Sri to discuss about trends in antithrombotic prescribing.
Thank you, Dr. Lim. I want to discuss the trends in antithrombotic prescribing in Asian countries compared to non-Asian countries. The slide shows antithrombotic treatment at diagnosis of atrial fibrillation for ischemic stroke prevention. On the left side, you can see that there's a high proportion of patients in Asia that receive no antithrombotic treatment and antiplatelet treatment. But there's a lower proportion of patients receiving vitamin K antagonists. The proportion of patients receiving NOAC is comparable to non-Asian countries. On the right side, you can see that the use of NOACs was highest in North America as compared to Europe, Asia, Latin America, and the rest of the world. This figure shows evolving treatment patterns in newly diagnosed AF in all 5 cohorts, Asia on the left and non-Asia on the right. The proportion of patients on anticoagulant treatment at diagnosis in Asia increased from cohort 1 to 4. In cohort 5, there was a smaller number of patients from Japan, so you can see that there's more antiplatelet use. In non-Asian countries, this proportion increased from cohort 1 to 5, and this rise was due to increasing use of NOAC. At the same time, there was a decline in the use of vitamin K antagonists and the use of antiplatelets. The proportion of patients received no anticoagulant remained unchanged during the 5 cohorts. NOAC prescription was highest in Japan, as you can see here on the left side, compared to other countries on the right side. In contrast, vitamin K antagonists were still commonly prescribed in Thailand, as you can see on the left side, compared to other countries. Nevertheless, there's a trend that there's an increased use of NOAC in cohort 5. This is because of the reimbursement system in Thailand. Only patients under the civil service welfare system and those who have private insurance or self-insure have access to NOACs. The first two health insurance systems, the Universal Coverage Scheme, which is available to all Thai nationals, and Social Security, do not cover NOACs at present. Now let's look at antithrombotic treatment patterns in newly diagnosed AF in different Asian countries. You can see that Japan and Singapore have the highest proportion of the use of NOAC, whereas Thailand and South Korea have the highest proportion of the use of vitamin K antagonist. China and India have the highest proportion of the use of antiplatelets. This may be due to the cost of the medication and the infrastructure for INR monitoring. So this slide shows antithrombotic therapy according to APHRS score. About 69%, 65%, and 71% of patients in Asia and non-Asia receive anticoagulant or antiplatelets, although the APHRS score is 0. According to guidelines, normally we do not recommend antithrombotic in patients with APHRS 0. On the other hand, 13.8% in Asia and 8.8% in non-Asia do not receive antithrombotic therapy. However, there is more, there's some reason that these patients still do not receive antithrombotic despite the guidelines. For patients with APHRS 0, 63% in Asia and 79% in non-Asia receive anticoagulant. And about 6.9% and 6.3% in Asia and non-Asia do not receive any treatment. Although the APHRS score is high, you can see that there's more use of antithrombotic, but predominantly it's an antiplatelet agent. And the main reasons why anticoagulants were not given in APHRS score of 2 or more in Asia was the concern of bleeding in Asia. In non-Asia was the perceived of low risk of stroke. In China, Japan, and Thailand, in Singapore, the main reason is the physician choice. And in South Korea and India, the main reason was the low risk of stroke. When compare anticoagulant only to antiplatelet with or without antiplatelet, again, you can see that in India and China, use more antiplatelet than other Asian countries. Now, looking at INR by country, the median INR was 1.9 in Thailand and Singapore, 1.8 in South Korea and China, 1.7 in Japan, and 1.6 in India, compared to 2.3 in non-Asia. So the median INR in Asia is lower than in non-Asian countries. The most frequent percentage of INR reading less than 1.6 was in India. The most frequent INR reading between 1.6 to 2 was in Japan, and the most frequent INR reading between 2 to 3 was in Singapore, and the most frequent INR reading more than 3 was in Thailand. To conclude, ladies and gentlemen, there are wide variations in antithrombotic treatment patterns among countries for the prevention of ischemic stroke in patients with atrial fibrillation. The proportion of patients on anticoagulant at diagnosis increased from cohort 1 to cohort 4 and 5 in Asia, and the rise was due to increasing use of NOACs. The proportion of patients receiving NOACs in Asia is comparable to non-Asia. And there is a higher proportion of patients in Asia that receive no antithrombotic treatment and antiplatelet than in non-Asia. There's a lower proportion of patients receiving vitamin K antagonists in Asia. The main reasons why anticoagulants were were not given in patients with APHRS of 2 or more in Asia is concerned of breathing risk. And finally, GARFIELD-AF data demonstrate a difference in the INRs in patients from Asia. So physicians from Asia tend to target INR in the patient lower than physicians in non-Asian countries. And with that, I thank you for your attention.
And this is entitled Stroke Prevention in Patients with Atrial Fibrillation and Comorbidities. And to start this chapter, Yukihiro Korutsune from Japan will give his talk.
Thank you, Chairman. Welcome to this tea time seminar. I and Professor Zavni will present stroke prevention in patients with AF and comorbidities. And I'll present the comorbidities of ACS and heart failure in this GARFIELD registry. And for DM and CKD, it will be presented by Professor Downey. This slide shows baseline characteristics of each countries and non-Asian countries for cardiovascular risk factors. Women's percentage about 40 to 50%. And the history of hypertension was not a big difference between Asian countries and non-Asia. Mean BMI relatively lower than the non-Asian countries. And diabetes mellitus was relatively lower in almost of all Asian countries, but it was higher in India. And hypercholesterolemia was high in Thailand and Singapore, and the other countries are lower. For the cardiovascular history, the heart failure is relatively high in Japan, and China is comparable, and the others are lower. Stroke rate was comparable. Vascular disease is relatively lower, but in China it was higher than the non-Asian country. And Charles-Basque score is relatively same as non-Asian countries, and heart spread is also the same. This is a percentage of obese patients in all countries. The Asian countries shifted to the lower side. So all countries' patients are relatively skinny than the other countries. There was a variation of ACS prevalence in Asian countries. In China, it's relatively high, and in India and Singapore, it was in the middle. And Thailand, Japan, Korea, it was in the lower side. The baseline characteristics of patients with ACS in Asia and Asia, non-ACS, and non-ACS in other countries, and non-Asia in non-Asia country. The age is 2 years higher in the ACS, and BMIs are comparable, and hypercholesterolemia, heart failure, and vascular disease, and CKD was higher in both Asia and non-Asia countries. Charles-Basque score is higher in ACS. There is a marked difference of the antithrombosis in Asian countries with ACS. It was markedly different from the non-Asian country. In the Asian countries, almost half of the patients are prescribed antiplatelet only when the patient with ACS. And the anticoagulant is used 43%. There's not much difference of anticoagulant in other countries with the ACS and without ACS. 1 year outcome of patients with and without ACS. Stroke and systemic embolism is comparable in Asia, but it was increased in non-Asia with ACS countries. Major bleeding is 1.5 times higher in the ACS, and all-cause mortality, cardiovascular and non-cardiovascular mortality is higher in ACS group. And new ACS and congestive heart failure is almost higher in ACS group. How about the heart failure? There's a variability in each Asian countries. In Japan and China, it was relatively higher. Singapore, Thailand in the middle, and India and Korea, it was relatively lower side. Median age was younger in the Asia non-AF group. Otherwise, it was comparable. And the history of hypertension was almost same, BMI same, and the hypercholesterol was not much big difference. Vascular disease and CKD was relatively higher in heart failure group. Charles-Basque score is increased in heart failure group. For heart failure combination, there was not much difference as we compared with the ACS group. Although the use of anticoagulant is relatively lower if we compare with Asia and non-Asia. One-year outcome, stroke systemic embolism is higher with heart failure. Major bleeding is increasing in Asia. And all-cause mortality, cardiovascular and non-cardiovascular mortality is also higher in patients with heart failure. And new ACS was increased, and congestive heart failure was increased in the heart failure group. Okay, so now I move on to next Professor Zavni to present comorbidities with DM and CKD and conclude for this part.
Thank you, Professor Yukiro, chairpersons, and dear friends. I'm going to speak now on baseline treatment and outcome of two other comorbidities, diabetes and CKD in patients with atrial fibrillation. The prevalence of diabetes in patients with atrial fibrillation in Asian countries we found was highest in India, followed by Singapore, and then also the Korea and Thailand, and the lowest was seen in Japan.